Good morning, good afternoon, and good evening, everyone, wherever in the world you may be joining us from today. My name is Francesco Del Carpio, and I am the CFAL York Operations Coordinator. I would like to officially open the first of our 2025 sessions in our Emergency Management and Hospitals and Healthcare Speaker Series, presented in partnership with the Thunder Bay Regional Health Sciences Center. I would like to begin today with the land acknowledgement. We acknowledge and recognize that many Indigenous nations have longstanding relationships with the territory upon which our campuses are located that precede the establishment of York University. The area is known as Toronto and has been caretaken by the Anishinaabe Nation, the Haudenosaunee Confederacy, and the Huron-Wendat. It is now home to many First Nation, Inuit, and Métis communities. We acknowledge the current treaty holders, the Mississaugas of the Credit First Nation, and that the territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. As this is an online event, our participants may be joining from various locations, so I strongly encourage you to learn about the traditional land upon which you are located. With this, I welcome our moderator, our speakers, and our participants from around the world. Welcome to our webinar. For those who may not be familiar with CFAL York, our center was established in 2020 and started its operations in 2021. CFAL York was created in collaboration between the United Nations Institute for Training and Research and York University with York Region to develop and deliver training and knowledge sharing as well as capacity building programs across 5 focus areas, which are disaster risk, emergency management and humanitarian actions, health development, environment and climate change, entrepreneurship, digital technology and economic development, equity, diversity and inclusion, and advancing the UN's Sustainable Development Goals. Without further ado, it is my great pleasure to introduce our moderator today, Misha Richard. Misha Richard is the current Emergency Preparedness Lead for the Thunder Bay Regional Health Sciences Center in Thunder Bay, Ontario, Canada. In this role, she acts as a subject matter expert assisting with the development and maintenance of emergency management governance, training materials, and exercises. Misha also volunteers as an editor for the Canadian Journal of Emergency Management and is happy to be a collaborator and facilitator for the CFAL York series. She holds a Master of Disaster and Emergency Management degree from York University and bachelor's degrees from Western University and Brandon University in the focus areas of political science and disaster studies. Misha, thank you very much for moderating today's session and your ongoing help in putting together this series. The floor is yours.
Well, thank you very much, Francesco, and it's nice to see you back for another year in this series. So I have the privilege of introducing our 3 presenters for today that are kicking off our 2025 series sessions. I want to read from the list here so that I get everybody's backgrounds correct. So first, I'll start off by introducing Maddy Laberge. So she is an emergency and disaster management leader specializing in emergency and disaster preparing, planning, response, and recovery within healthcare and other complex organizational systems. She has coordinated numerous complex healthcare responses, including the COVID-19 response, the British Columbia 2021 heat dome, and numerous extreme weather events, droughts, floods, wildfire seasons. She's a respiratory therapist by trade with a master's degree in emergency and disaster management. Maddy believes in fostering a culture of preparedness and safety while implementing strategic priorities, policies, and initiatives across healthcare facilities. So thank you, Maddy. Next, I'll introduce Gloria Hertz. So Gloria is a disaster and emergency management leader within healthcare in British Columbia. She specializes in business continuity planning and emergency response. She's coordinated numerous complex healthcare responses, including air operations of the 2021 Fraser Valley flooding, the reception of Yellowknife evacuees in the summer of 2023, as well as numerous other extreme weather events and local healthcare site emergencies. She is a registered nurse specializing in emergency nursing with a master's degree in disaster and emergency management. Gloria believes in equity-informed, sustainable planning and response that reduces long-term risk and fosters community wellness and resilience. And last but certainly not least, I have Joel Van Huizen, who's a health emergency management specialist working within healthcare in British Columbia. He's a subject matter expert for HEMBC in long-term care emergency management and currently supports long-term care, assisted living, and home health care emergency planning in Metro Vancouver and the Fraser Valley. Joel has responded to multiple healthcare events in British Columbia with deployments across the province. He has worked alongside local, provincial, and federal response agencies through events including the 2021 Fraser Valley flooding, multiple wildfire responses in 2023 and 2024, and regional extreme weather events. With a background in education, Joel strives to eliminate silos and promote the voices of frontline staff when planning and responding to emergency events. So thank you very much, all three of you. And now, since we have a lot to cover, I just want to touch on a little bit of housekeeping before I turn the microphone over to you to begin your presentation. So for those of you who haven't been with us before, I will just highlight that we do have the chat, which is open for discussion among all attendees. However, if you have any questions, please ensure that you're dropping those into our formal Q&A. I'll be monitoring our Q&A and we'll be taking up those questions at the end of the presentation. So hopefully we can answer your questions as we go along, and if not, we'll try and address them at the finale. So thank you very much for everyone attending, and to our panelists, now the floor is yours.
Hello, everyone. You can see my screen got a thumbs up. So thank you all for joining today. I'm so honored and excited to present on the Inter and Intra Health Authority Relocation Toolkit. I'll be referring it to as IHAR going forward. I did want to acknowledge that Joel, Gloria, and myself are coming from the unceded and ancestral territories of the Musqueam, Squamish, Stolo, and Tsleil-Waututh Nation. As we advance this field of emergency and disaster management, I really want to put forward the call for us to ensure that cultural and safety and reconciliation is a key consideration in everything we do in all phases of emergency and disaster management, from preparedness, mitigation, planning, recovery, response, and that we listen and learn from the knowledge keepers and ancestral knowledge that the Indigenous people on whose lands we currently reside. And you will see how that call I put forward is incorporated in our toolkit that we're presenting on today. We will go through a little bit of background about HEMBC, which is what we work for, and then how IHAR came to be. We'll talk about the process, the key features, and then some case studies regarding how we've implemented IHAR and how it's gone very well, in our opinion, and some key takeaways at the end. About HEMBC. HEMBC was founded in 2013. It is a consolidated program. That means that wherever you are in BC, doesn't matter what health authority you are in, HEMBC is there. So we get to work together. It's quite special in that way that we are not siloed. I can reach out to my interior health, my northern health colleagues, and share that information, which provides a breadth of knowledge and learnings that we would not normally have if we were just working for one single health authority. We also work at all levels, from provincial, local, national, and international, and as well we have partners across Canada and the Pacific Northwest. We have three primary programs. The one I'll be focusing most on is our 6 health authorities of BC, so 5 local and 1 provincial. We as well provide provincial psychosocial services such as the MRT, mobile response team, and the disaster psychosocial program. We also have a provincial program that looks at provincial coordination, that when we have large responses or require a provincial lens on responses, emergencies, and planning, as well as operational support that has the stuff. So that's like structures. You see in the image our very fancy mobile medical unit, which is a hospital in a box. We have DAXs as well, and a variety of medical supplies and temporary facilities that can be used in emergency and disasters. About HEMBC. So this is more from our operational perspective. We provide expertise from everything. We are a jack of all trades. We do it all. We have education and tools. We help essentially the health authorities inside the entire disaster life cycle: prevention, preparedness, mitigation, recovery, and response. And really, at the end of the day, what our job is to ensure that patient access and flow is maintained. And really, what does that mean? It means that patients come into our healthcare system and they get the care they need as quickly as possible, and then back home. What we have found is that when any any corner of the healthcare system you pull on, what happens is it backs up into our emerge departments. And what we want to do is really prevent that. We want to have a resilient system, and that is the main purpose of our program. You know, how do we get patients in and patients out when there's a heat dome or flooding or I don't know. So many things you can't even think of. It always surprises us what pops up. So how did we get here? Now on to the good stuff. In the summer of 2021, we had a horrific wildfire season. We've had some wildfire seasons that have been challenging over the years, but this was one of the most complex ones that we've had in recent, well, really in recent history, and one that our program in the last 10 years have had to deal with. It was incredibly complex that year. The Lower Mainland, so this is not close. We received over 800 long-term care, independent living, and assisted living evacuees from hundreds of kilometers away. So Interior Health is who we evacuated from. And for those, we did some Googling to try to have that's from Timmins to Sudbury or from Toronto to Hamilton. This is no small distance. And unfortunately, we do try to avoid air travel at all costs. How highways closed and were burning, we had to have air travel. And this is where I learned that plane manifests can be wrong. TV lied to me. I was pretty sure that was, the numbers I could count on, the names I could count on, and that was incorrect. We did our best, but it was incredibly challenged. We didn't have clear processes. We weren't prepared for that sheer number of people to deal with. Our systems always tight. All of ours are. And when that plane landed, there was people on the plane that weren't on the list. There were people on the plane that were on the list that weren't there. We had piles of identified, unidentified luggage and medications spread through various sites. Some stuff that we never found their owners to. There was a large population with dementia. They had no identification. We weren't sure if they required medication. The staff that came with them were exhausted. They'd been working for hours. And we did our best, but all of us have a little bit of trauma from those 48, 72 hours coming out of there. And at the end of the day, we were extremely lucky that there was really no negative outcomes for those patients. And I still have some occasional nightmares about those events. But in saying that, we knew at the end of this pretty much immediately as the patients were landing that we had to do better and that this couldn't happen again without a really formal system or process. And so with that, I'm going to pass it over to my wonderful colleague, Gloria, who will take you through the next steps.
Thank you very much, Maddy, for giving us the background and really painting, I think, a very good picture of what that motivating event was for the creation of the IHAR project. As Maddy described, we had never moved people such a great distance before, from the interior to the Lower Mainland, and that posed some significant challenges of two different health authorities with different staff, different systems. We also accepted some residents that were not being housed by the health authority, but rather with private long-term care facilities. So there's a lot of complexity involved. And in 2021, actually, while those wildfires were still raging, the kind of initial structure of this project started to take shape just within our Lower Mainland group. We weren't sure if we were going to continue to receive more people. The forecast was not looking too promising. And so this project really began like a little bit of a bootstrap effort between our Lower Mainland team to try to put some immediate tools and processes in place in case we were going to receive more evacuees, and then also to support our repatriation. The good news was that that week of August 15th truly was the most intense of that wildfire season and of the evacuations. And so we did not receive any more evacuees into the Lower Mainland. And then we turned our attention, as we so often do, to the after action review process. And as we started to debrief with everyone that had been involved across the province, we realized that the work that had kind of started locally as this project could be a really good way to actually action some of these recommendations that were going to be coming out of the after action review process. And in fact, we realized that if we were to take this and make it a provincial project, that could address a lot of the challenges and the learnings that had come out of that experience. So in January of 2022, we formally launched a provincial working group that was going to be looking at how we were going to move evacuees, both within health authority regions, but also across one region to another. This provincial working group had one member from each HEMBC team representing each of the regional health authorities. And so those folks were plugged in with the health authority of their region and could pull on their subject matter expertise and represent their experience and needs. We also had a representative from the First Nations Health Authority, and we had a representative from the Ministry of Health Emergency Management branch. They had been a partner with us in the 2021 evacuations, supporting getting organized some of the air travel that we utilized. The next several months was a very, very intense development process of sifting through these lessons learned and trying to incorporate them and really map out what an evacuation like this could look like going forward. And then probably the most valuable thing we did before, releasing our initial version of this project was doing province-wide consultations. So I know how challenging it can be to get that kind of engagement with health authority staff, but that's why we really put a big pressure to get this work done quickly, because we wanted to capitalize on that recent event, which was so fresh in people's mind. So we had a lot of still engagement as a result of that experience being front of mind for people. So we held once we had kind of completed our first draft of all the deliverables, we held several province-wide consultation sessions. They were kind of like a workshop format where we demoed to these people, and this was health authority directors, clinical leaders, we had physicians, we had people from the transport groups within the health authorities. So it was a really diverse profile of people who could bring different perspectives. And they got to take a look at what we had been developing and provide feedback. Yes, this is going to work. No, that's not. This is too long. That's not good. And what I want to share as a good learning from that experience, what was really valuable is that we did them provincially, and so that helped break down some of the silos. It was really helpful for folks that had been on the receiving side to be in the same groups as people who were on the sending side to get to hear what the different perspectives was. Because a big challenge in a project like this is getting agreement across the province and across these partners about what that process should look like for evacuation. So that was a really, key milestone for this project was getting that across the board review of the documents and mixing them up as they reviewed so they could, hear from each other's own mouths what the various opinions were. We took those the feedback that we got, implemented it, alongside that developed education materials, because obviously you can't just deliver a product and step away. The education component of this is huge, to continuously go out, especially in the context of healthcare with the amount of turnover, to continuously go out and refresh and educate folks on this. And in time for the 2022 wildfire season, just at the end of June, in the nick of time, we did release the toolkit in its entirety. It was over 20 tools and resources consolidated into one shareable format. And then our group launched into education and then evaluation. That particular wild summer season, 2022, was a bit of a quieter one. I can say the Q word now that it's in the past. But so we continued our evaluation of some smaller scale responses, continued the education. And then in 2023, we had a significant wildfire season, not only in British Columbia, but also Yukon and the Northwest Territories. And we had a lot of opportunities to see whether what we had developed would actually be useful in practice. We had a number of evacuations that did utilize components of the toolkit, and we actually had a couple that did not. And that ended up being, I think, a good credit to the project moving forward, because it validated to a lot of people that these processes were effective. Nonetheless, and by the way, Joel's going to speak more about some of those examples. Nonetheless, there's always room for improvement. So we continue to build upon some lessons learned from that wildfire experience, and released an updated toolkit in 2024, very similar to the original one, but it contains 2 more new deliverables, as well as a version that can be shared with external partners. So that version is quite similar to the internal toolkit. It just removes some of the language and content that's specific to the BC healthcare system. And so it's shareable with external partners for them to kind of use and abuse as they like for their own planning. And in addition to that, we are working towards a provincial education module. So looking at how we can have some kind of video interactive asynchronous education to really make the use of this even easier for staff in the future. And that's kind of where we're at now, is in the sustainment process. We're trying to figure out what this project looks like moving forward, how these materials can continue to be evaluated, how often they're refreshed. So that's kind of the phase of the project we're in right now. Now to some more detail about the project itself. If you're not familiar with the iHeart Toolkit, I'm going to take you through a couple of the key features. So what you're seeing first there was really our mission, not just an objective, but truly the mission of our work was to bring about a patient-centered, risk-based, culturally safe approach to relocations. This was really paramount to us because we as planners know that in an emergency, especially when you're knee deep in a planning cycle and a response cycle, we can sometimes get tunnel vision. And that's not a fault of anyone, that's just human nature. So we really tried to embed some places throughout the toolkit where we can stop and pause and remember that the people that are being relocated come first. And everything that we developed, honestly, we kept going back to that mission and would ask ourselves, does this meet this mission? Does this support and enhance our mission of patient-centered, risk-based, culturally safe approaches to relocations? I'll also just add, we use the term relocation just to indicate that this could be an evacuation to a final receiving area, it could be to a staging area, it could also be a repatriation. So we use that term just a little bit more holistically to encompass all the different types of movement that a person might make. And then our other objectives were, as expected, to increase the preparedness of both potential sending and receiving sites. We wanted to improve the understanding of evacuation processes and those critical actions across the province, as well as get some agreement about how we were going to manage information and data. And we wanted to reduce cognitive load for staff and leaders during stressful situations. I really want to say that that experience that Maddy described, it was extremely challenging, but I hope everyone knows that that was of no fault to any of the staff that were working. It's really challenging to move 100 elderly long-term care residents when there is a fire coming down a mountain and sparks and ash in your parking lot. Like, that's how close it is, and you're evacuating your family because these are community level evacuations. So when we talk about those challenges, we know that it was not for any shortage of care and competence from any of our staff in healthcare, but really that we need to do a better job reducing their cognitive load to make them more effective as they want to be in those situations. And lastly, the key features, we looked at the whole spectrum of the response of an evacuation or relocation, I should say, from activation, coordination, preparedness, transportation, and then reception. That was kind of the scope of the toolkit. So what I'm going to do next is take you through, I believe I have 6 examples of different tools. Don't have time to go through all 21 or 23 now, but we've kind of chosen these to highlight a few that I think might be interesting to the group. So the first is the decision support tool. This was one of the newer ones we added in the version 2.0. As you guys know, evacuations are an extremely complex, the decision to evacuate can be extremely complex. Obviously, when an evacuation order has been issued, there's no choice there. You know, the community has said you got to go. But what about when there's an evacuation alert? How do we support our health leaders in making those decisions? So this tool was something that was developed over a number of years in our interior health region, which has the most experience having, unfortunately, to make the decision to evacuate. And so we pulled it together into this tool, which is intended to guide conversations around evacuations and really support their decision making. So this is something that can be utilized by leaders in an emergency operations center, and it essentially takes them through a couple of key risk considerations. Things like a deteriorating weather forecast, the risk of losing an escape route, the proximity of the threat, if there's any threats to infrastructure, what impacts there are to local staffing, what's the situation of local non-emergency transport resources. What we learned is that a lot of the evacuation movement was not being done by ambulance. It was being done by our non-emergency transfer partners. So what's the status of that within the community? And lastly, what's the number of patients or residents or clients that need to evacuate, as well as their frailty? So this is a tool that helps kind of, you know, rank the risk, low, medium, and high, to help standardize the things we're thinking about when we're making the decision to evacuate. And what we found actually was this was being utilized almost on a daily basis in EOCs, and it allowed leaders to track how the risk and how these different components were changing from day to day to really support them in their decision making. So this has been really useful for kind of leaders and administrators. So what you'll see from everything that we're going to talk about today, this project really covers, there's something in it for everyone. So there's something like for the leaders, there's a decision support tool. This flow chart here is not only for leaders and administrators, but it's also for all staff. The reality is most people involved in evacuation, especially a community level one, it'll be their first time going through that. And that can be a monumental task to just wrap your head around everything that needs to take place in an evacuation. So we created this flow chart, which can be utilized in almost every setting along the way. It can be utilized during training and education, just-in-time training, to help staff that are asked to participate in an evacuation wrap their head around what all the different components are of the process. In addition to kind of mapping out some key steps, some critical actions are listed just to get them thinking about what some priority tasks might be. And one feature of this flowchart I want to highlight, it speaks to something that's listed in a couple of our different documents, is the stop checks. So we learned that the actual phase of transportation can pose the highest risk to our clients, that physical movement from one facility to another. And so one of the principles of our project in this toolkit is the stop checks before and after movement. So before you initiate movement, we ask that you stop, and you ask, is this still required? Sometimes we've been planning for 2 days or a day and a half for what is about to take place, but have the conditions changed? Is this still the best plan? Is there a new route that actually would be safer and better for our patients? This is really to support us with removing some of that tunnel vision that we can get in the heat of a response, to ensure we're not missing a better alternative that may have opened up just in the nick of time for our patients and our residents. And the second stop check is at the receiving end. So upon receival of that resident or patient, stop. Is this still the best place for them to be here? Has their condition changed? As Maddy said, people were traveling from the interior hundreds of kilometers from, akin from Toronto to Timmins. That's a long way to go, either by bus or by airplane. And is the place that we've allocated for them still the best place for them, or do they need to go to the emergency department or to a higher level of care? So this is really intended to kind of bring us all on the same page about what the evacuation process will entail. Now, the sending site list, this really speaks to information management. Obviously, when you're transferring people within your own computer system, it can be a lot more straightforward because you have the same system, you can look up their records, both at the sending and the receiving site, and you can make adequate preparations. But when we're transferring people across incompatible documentation systems, it really poses a challenge. How do we make sure that we place this individual at an appropriate receiving facility? We need to know something about them more than just their name and age. We need to know their mobility status, their medical, considerations, because not all of our facilities have the same capacity. And likewise, we need to know some of this information to organize transport. Can this person, do any stairs? Do they have any mobility aids that they require? That all impacts the type of vehicles that we can use. So a lot of the work we did was around getting some provincial alignment on what is that key information that we need to support our planning and decision making. And those things are now listed in our sending site list, which you're just seeing a sample of right there. This is a list that can be filled out. We actually recommend ahead of time and then update it sort of quarterly, or if you're in a high hazard season, more frequently, so that it's less of a labor intensive process when the evacuation comes. But this contains information about the demographics of who is being moved, including whether or not they identify as Indigenous, or if they have other key cultural considerations. That really allows us to plan to have those appropriate cultural supports at the receiving end. The recommended best mode of transport, according to the clinicians who know them the best and take care of them day by day. A mobility assessment, including what aids they need, how many steps they can take. If there's any infection control precautions. The 2021 evacuation was during COVID, and we evacuated, one of the buildings was on outbreak at the time. That posed some real significant challenges with how we were co-moving people at the time. Other clinical considerations, like, if they're on dialysis or have special wound care needs. If there's any behavioral considerations that may impact travel. So if somebody needs, somebody to accompany them, if there's any risks potentially to staff that they may encounter along the way. And of course, their primary contact and receiving information. So there is a way to collapse this list and make it a little bit shorter for emergent evacuations, but we've actually found really good success in advocating for these to be filled out in advance in order to make sure that we can decrease the labor of this in the moment, but also have all the information we need for effective planning. Moving right along, we've gone from leadership and administrators. This checklist right here is right down to the frontline staff that are actually working with the evacuees. So this is a checklist preparation for relocation. And we really adopted this concept because it already exists in healthcare. When you move a person from one facility to another, from one unit to another within the facility or a hospital, we give handover. That's a standard practice in clinical settings. So this is where we really adopted that practice from. This is a checklist that is filled out at the front line for each resident. It's ticky boxed so that it can be really quick, and once you've done one, you can just breeze through it. The first page provides information about that individual, about some of their key medical considerations, key safety considerations. And then the second page is a prompt for the person at the front line to pack all of the relevant things that need to be packed, including mobility aids, medications, potentially any narcotics or other controlled substances the individual may require on transport. Any key personal items. It ensures that the individual has an identifier placed around their arm, which indicates their name, sending location. It prompts the caretaker to label any belongings that are going with them. And then this is actually a triplicate that we printed and distributed across the province to some key strategic stockpiles. And once it's filled out, the triplicate, a copy stays with the sender, a copy goes in the medical chart, and then one copy goes with that individual at every step of the way. So what this means is that in transit, let's say at a staging area, when this person encounters a group of care providers that they've never met before, that care provider can quickly look up this handover checklist to know a little bit about this individual and provide them key care should their condition deteriorate or should they have something that they require en route. So this is right down to the frontline level. Yeah, as I said, mimicking the handover process. I've got two more checklists I want to share with you just to bring us through the entire process all the way over to reception. This one here is for during transport. As you could just imagine it, you're on a bus with 30 to 40, long-term care residents, traveling, 3 to 4 hours on a highway to get to a different region. You're not sure what's going on back home in your community. You're leaving your community as much as these residents are. Very, very stressful. So we compiled some of the learnings for just one checklist for the leader of whoever is the designated lead on the transport vehicle. And this just acts as a prompt for them to deliver some essential care to the folks that are on transit for potentially a prolonged period of time. So this just includes like that, again, it's that decreased cognitive load. So this is just some prompts to, essential personal care for some of the residents, like food and water, or repositioning as much as they can in the seats, stopping for bathroom breaks if possible, or offering mental health support. Prompts for assessment and medication that folks might urgently need during transport. And also, this was a good learning, a prompt for communication. It's really great when you're on that bus to call us at the sending or receiving site every once in a while with an update so that we know you're traveling along safely. Again, these things might seem intuitive to you or me right now, but we don't want to take for granted how stressful that situation is, and so I've developed this quick one-pager for every transport vehicle. Meanwhile, over at the receiving site, we compiled a lot of the firsthand learnings from all the Lower Mainland sites that received evacuees into a checklist so that if you're the site lead or the site director receiving evacuees for the first time, you don't have to figure it all out all over again. So learnings such as increased registration staff, increased OT, PT at the reception moment, increased linens, toiletries, like all of those little things that can make a huge difference at the point of reception have been included in this checklist to help guide the receivers through some key considerations to make it as smooth as possible on their end. So with that all said, I'm going to pass it over to Joel, who can talk to you guys a little bit about how and when we've utilized some of these components.
Thank you, Gloria. So I'm going to speak on two case studies. One is interprovincial, one is local to within one of our regional health authorities. And our goal in sharing these case studies is to showcase how the tools have been used within BC and some of the positive impacts we've seen from the utilization of these toolkits. I'm going to start by speaking about the evacuation of Yellowknife, specifically the Stanton Territorial Hospital in August of 2023, and the role that HEMBC and BC's health system played in supporting that evacuation. So on the screen right now, you'll see a couple of photographs. One is the Canadian Forces aircraft that was used to transport some of the medical evacuees from Yellowknife to Vancouver International Airport. And then broken up on the right-hand side, you can see a picture of our staging area involving our non-medical patient transportation and our BC ambulance transportation that was on the ground at the airport to move the residents from our receiving site into the health system. We can go to the next slide. And I'm going to start by talking about the activation process. So beginning on August 14th, rumors of a possible evacuation from Yellowknife began to circulate, and this is due to the deteriorating wildfire situation in the Northwest Territories at that time. Around August 15 or 16, HEMBC began doing specific advanced planning for the reception of medical evacuees into the Lower Mainland by air. And around this time, the IHAR toolkit was shared with the Northwest Territories, and we began some interprovincial territorial coordination. Specifically, the sending site list was shared with the health system in the Northwest Territories, and we began to get updates from the sending site list of who the possible evacuees would be, what their transportation needs would, and that allowed us to start our advanced planning of where we would fit them within our system, whether that was acute, long-term care, or other needs. And it's hard to express just how dynamic the situation was. It was changing hourly. It was changing sometimes multiple times an hour. We got dozens of the sending site lists sent to us. And I believe Gloria was handling that constantly. So she was an absolute champ during that time. If you go to the next slide, the response, what you see here is an image taken from our preparations. We were going to use this area of a decommissioned private air terminal at the Vancouver International Airport to bring evacuees off the aircraft and hold them here for assessment. We ended up using this space, keeping them on stretchers, so these cots were put away. But we started to physically move assets onto the airport around August 17th or 18th. So this was our lower mainland HEMBC team and our provincial HEMBC team. We were staging supplies and equipment using some of the IHAR tools for what a receiving site would need. So that involved moving medical supplies, moving a lot of stretchers from private and public sources, started coordinating with Canadian Armed Forces, RCMP, BC Ambulance, private medical non-emergency transportation, as well as being prepared for an evolving timeline. So beginning on Thursday, we were expecting evacuees that changed into the Friday throughout the day, and it kept on getting delayed and delayed. I'd like to point out, if you can go back to the previous slide, actually, Alberta Health Services took so many of the evacuees. We were initially expecting to receive potentially up to like 70 evacuees, and Alberta Health Services kept on finding more space and more space. So our sending site list was evolving, and some of the more critical needs were taken care of within Alberta or planned to be taken into Alberta. So the situation required a lot of back and forth communication. If you go to the next slide, this is a picture of the looking down onto the area. You can see there's a doorway sort of in the middle. That is where patients would come in via stretcher from an aircraft, and then they would move onto either side of this table. And when Gloria mentioned the stop checks, this was the second stop check. So the first stop check when they arrived was actually triaging them on the aircraft before they were removed to determine which patients were most critically in need of decanting off the aircraft. And then they were brought in here where they're given a more full assessment by 3 regional health authorities in the Lower Mainland, where medical personnel were evaluating them and assessing them for their needs. This was 23 hours straight deployment for the majority of us at HEMBC who were there. We started around 7 in the morning. I think I got home around 6 a.m. the following day. We drank hundreds of cups of coffee. And we were going through a lot of these learnings. There was dedicated personnel for moving luggage. There was a single exit from the building to ensure that every patient who left was confirmed 3 times, I think, in triplicate to make sure we knew where they were going. There was en route communication once they were within the BC health system. So that was, we were working very carefully to ensure a lot of these learnings. And then if you go to the following slide, we immediately pivoted within, so this event ended the morning of August 19th. That evening, the Okanagan wildfire situation occurred where the fire crossed the lake in the Okanagan and led to the evacuation, and internally within that region of over 950 long-term care residents. And so we needed to immediately pivot to a larger number of evacuees within BC's healthcare system. From a BC perspective, we had to pivot from an external response that we were supporting to an internal response within BC, and we had to immediately pivot. And at the same time, we also had to manage the recovery process, which involved caring for evacuees from the Yellowknife for well into September, planning for their repatriation, which was a long, drawn-out process. We took a lot of learnings from that. One of the things that we learned is we need more personnel assigned to repatriation and more dedicated resources than we had expected. So the repatriation, while it doesn't seem really glamorous, is a critical component when you are planning for moving residents, especially when you're talking about a community level evacuation. And it is an area that we had when Gloria mentioned some of the additions to the iHeart Toolkit. A lot of that was we learned a lot about repatriation following the Northwest Territory evacuation. So I just put an image on there of the emergency management continuum to show that we immediately pivoted to another response. And so it was critical for us to have these documents in place to ensure that our staff knew what they were doing over a 3-week-long continual response process. That was incredibly exhausting for everyone involved. But if we go to the next slide, I'm going to talk about a much smaller event that was just within one of the regional health authorities. CareLife Fleetwood is a long-term care site that's owned by the health authority and operated by the health authority, but it also has some complex patients there who are vented, some patients who are in the process of being decanted from the acute site in the area. So it's not just long-term care, but what you see here is an image from one of Environment Canada's yellow weather notifications. And what I've circled in red is prolonged cold weather leading to residential infrastructure failure, pipe freezes. And we had pipe freezes at CareLife Fleetwood that caused massive flooding and caused the power to be shut off during a cold snap in the Lower Mainland. When I got the call on Saturday morning and I arrived on site, the internal temperature of the building was somewhere around 4 to 6 degrees above Celsius, and these are medically frail patients. So we had to quickly pivot to how do we care for these residents? Where do they need to go? And if you go to the next slide, I'll talk a little bit about the activation. But in this case, because of the events of 2023, in the Lower Mainland, we had been advocating for all of our long-term care sites to complete the sending site list in advance, with an understanding that there's patient turnover, you'll have to update the document, but having some of it filled out in advance is a real lifesaver. That was our hypothetical, but as it turned out, CareLife Fleetwood had updated that document within a week prior of this event occurring. So when the cold snap occurred, when the burst pipe situation occurred, there was system failures and an internal evacuation, they were able to identify very rapidly, if you go to the next slide, they were able to identify which patients were on site, what their transportation needs were. They were able to arrange transportation. They were able to set up their EOC. They were able to safely keep the patients on site in the areas with power, and they were able to immediately present their needs to the health authority regionally, and we were able to start planning. What this meant was local incident command, within the 6 hours of the event occurring, was able to identify tentative areas for relocation for these residents, and we had buses and ambulances on site waiting to go, and we were able to surge the resources to the site in case we needed to immediately evacuate while we assess the situation. So the recovery process, I think, is another highlight of this event. Because the iHeart documents had been completed, within 30 hours of the event occurring, we were able to pass off the management of the patients to the regional access and flow teams. And that allowed our HEMBC team to pivot to 6 other burst pipe situations that were occurring in the regional health authority, including one that had flooded a community emergency department in a hospital that was a municipal fire hydrant pressure, a 4-inch pipe that was going for 15 minutes, just pumping water into the ED. So we had one ED totally out of commission. We had another contracted long-term care site that had 30 patients displaced. Overall, system-wide, Fraser Health had lost approximately 1% of its long-term care beds that were contracted. And that's at a time when our actual capacity was, there was maybe a vacancy rate of 0.01% at that time. So we were losing a significant amount of capacity. And like Maddy mentioned at the beginning of our presentation, we are going to see that backlog back into emergency department. So having the IHAR documents accessible and utilized appropriately allowed a quick response, allowed us to pass off the recovery process back to the health authority, and allowed us to focus on the crises that were occurring throughout that week. And that's very quickly our 2 case studies. I know that was really quick, but we really wanted to be able to speak to some of the questions. So I'm going to pass it back off to Maddy for the takeaways.
Thank you. Just to go quickly at the end, I think really what we want to highlight is the World Health Organization has identified that climate change is the most significant health threat of our time, and it can undermine the last 50 years of advancement. When this escalated, we are now forcing our healthcare system to unprecedented demands. We're already tight, we're already surging, and now we're trying to manage climate crisis. In this context, I really want to put the call out for us to work together. Emergency managers, planetary health, climate change experts, disaster response specialists, facilities management operations, and to break down those silos, but the barriers of the language that we use across. We recently found out that our climate readiness did a portfolio level assessment of all of the sites in a climate perspective. We call that an HRVA. So we need to be talking to each other to break down those languages in our areas and share the resources, because we can't do this together. And that's one of the reasons we've made IHAR publicly facing in Word format, so you can change it. You can make it fit your area. And we would love, if you do use it, to give us feedback. Let us know how it goes. We really need the path forward as unity and innovation together. We need to bridge the gaps across emergency preparedness. And we want to ensure that no facility, patient, or community is left vulnerable in these escalating climate crisis. We also think IHAR has a place that could be adapted into the prison system or social housing. It potentially could be used in medical or mental health and drug treatment facilities. It has the capacity to be adapted to support a variety of other programs. And so we're so thankful we got to share this with you all today. With that, that's the end of our presentation, and I'll pass it back to you.
Lovely. Thank you so much. I know I was watching the clock and I was thinking there's just so much to try and share. And I know we've had questions coming in, but I mean, the first question that I think everybody would like to ask is, where can they access this material? Perfect. Okay.
Done. It's in the chat.
It's gone to the hosts and panelists.
Oh,
Are you able to
Yep.
flip that? So Maddy is going to put the link. There you go. Thank you. Rapid fire response there. Very good with the Zoom capabilities. So for everybody that's wondering where these resources are that Maddy just said, you have the ability to modify these to fit your own organizational or regional purposes. They're there for you on that site. So start there and go through those tools. So I think that addresses question number 1. I wanted to point out, just as somebody that was also here able to observe your presentation, there's some great elements here that even if staff aren't in a position, because you don't have the people power to make some big changes in your organization right now. For a lot of healthcare facilities, it's one person doing something off the side of their desk. Just knowing that these resources exist, even if you aren't able to operationalize these things immediately, knowing that they're there and prompting some discussion with colleagues within your organization. So I think you had mentioned dementia patients that had arrived and don't have any ID, and do they have medication, and wondering, this person can't articulate to you perhaps who they are and what was supposed to be coming with them. I know, Gloria, when you were sharing those checklists and just mentioning controlled substances versus saying medications, going with someone, it's like these are different considerations that can get maybe some discussions going at local levels for folks. Because I know some people were saying here, I think there was a question in the chat where somebody said, you know, can HEMBC like help advocate for funding for long-term care home emergency managers? And it's like, of course, like we all kind of have to pull together. So certainly you've put in a lot of legwork to make sure the resources are there, but I don't know what the advocacy looks like to say we need to have more people doing emergency management at the local level, especially in things like long-term care, which I think sometimes get forgotten about. Gloria, you just unmuted yourself, so I think you have commentary to share.
Yeah, I just want to speak to that because I saw a couple sort of questions like that coming into the Q&A. Just to say, you know, I don't want to show up here and give anyone the impression that we've got it all figured out and we've got it all right. Because let me tell you, I really appreciate some of those challenges that I'm seeing. The health system is complex, and we have our health authority owned and operated facilities, but then there's also like affiliated sites and you know, in long-term care is privately owned sites that we don't have a really reach into. And even across the health authority and other spectrum, there's varying degrees of resources for emergency management. And what I will say is really what advocacy is a big role for us. At every table that we find ourselves at, we are sharing these learnings and we are advocating for more resources at every level of health. In the context of climate change, it's not something that is a nice to have. It's something that in the coming years is going to be a need to have. So we certainly do advocate. How successful we are in that advocacy, it's slow and it's arduous, but we're going to continue to chip away at it. We don't have, you know, legislative authority over our partners that we work at, so we really utilize engagement, you know, getting buy-in. It's a slow process of convincing people that this is valuable, and that's a challenge that we face every single day. And so yeah, just to kind of acknowledge some of those questions, absolutely, we're advocating. Our scope is also limited, but we will always be a voice for more resources. And in the interim, our main strategy is really just sharing examples and getting buy-in. You know, one champion, two champions, that's all you need for culture to change in a certain place. We really operate by that.
I just wanted to answer
Yeah.
two questions I see. One about ICS. We didn't really touch on this, but we had so many EOCs going. So ICS, we don't use, at the end of the day, we make ICS work for healthcare. We are not Puritans when it comes to incident command. We make it fit. We do our best, but we do use EOCs, and we had them open at various levels. So for the Northwest Territories and then quickly into the interior, we had local receiving EOCs, we had staffing EOCs, we had transportation EOCs, we had regional EOCs, we had cross-health authority EOCs, provincial EOCs. So within this, the toolkit was supported by the EOCs that really helped the communications. The other question I saw was about the patient information for the Indigenous patients. We worked closely with our internal resources. The BC Health Authorities are very fortunate to have a very robust Indigenous patient navigator support system. So within the Northwest Territories response, we had a large group, I think of 6 or 7 Indigenous patient navigators that came and met with us at YVR, supported the Indigenous patients from the moment that they landed and throughout their whole journey. So they had somebody, while they're from different nations, they had somebody who understood that there can be complex trauma involved in being forced to relocate, especially when we found out some of those people had never left, and the only time they'd been forced from their homes was from residential school, and the re-traumatization around that. So having the Indigenous patient navigators wrap around and support throughout the evacuee's entire journey and repatriation was something that was really the first time I felt that as a health authority, as a response, I saw as really walking the path of reconciliation and cultural safety in a way that we had really never done before. And that was in part because it is embedded in the toolkits. It is part of the questions we ask and the stop checks going forward.
Great.
Orange man.
Oh, I know. Sorry.
I can't talk
was like,
anymore,
I
but
saw
let's
that
go.
one. I was like, ooh. So we've hit time, and I do want to be respectful of all the attendees' times as well as our presenters. Francesco, our coordinator from York, did throw it in the chat that if we didn't get to your question, or if you think of something later that you would like to have one of the speakers hopefully address, you can email Francesco. Again, the email is in the chat, and he will make sure to filter those over. Again, in the chat, we did have the resource link for you so that you can get to all of those tools. I don't even know where to begin. You guys have covered so much. I think, Joel, you had said before we kind of opened this webinar this morning that, you know, it's a part of the being proactive versus reactive. So you guys are kind of getting ahead of the curve, and it's really beautiful to see. And I think that's the kind of motivation that those of us will be happy to start off this year with, especially pre-wildfire season. So again, really, really appreciate all of our speakers today sharing your lessons applied from the BC coast. So Francesco, final closing words, over to you.
Yeah, thank you so much. Just quickly as well, thank you so much to you, Misha, for helping organize the session and for moderating today. Thank you, of course, to our speakers. That was a wonderful presentation. I think it was a great way to start off our 2025 series. And as Misha mentioned, this is a timely presentation, so thank you so much. I see a lot of thanks from the audience as well, so I think it was really well received. So thank you so much. And of course, thank you to our audience members for taking the time to be here and joining us and coming back for the third iteration, I guess, of the series for 2025. So we're glad to see that you're all still enjoying it and finding it useful and coming back. So thank you so much for all of the support. And as a reminder, this is a monthly speaker series. So we'll be back the first Monday of every month. Which I believe is also March 5th. So you can join us again March 5th for the next session. And this session is, of course, being recorded and will be up on our YouTube channel and on the series page. So if you would like to revisit the session, please do so. And please feel free to share it within your network. And if you know anybody who hasn't registered yet, share that link as well. Registration is always open and free. Yeah, so with that, just one last big thank you to everybody. I hope everybody has a great day. Thank you all so much. That was a wonderful session.
Thank you for having us. Have a wonderful day.